Yes, thank you, thanks Chen and thanks Sasipong, moderator and co-moderator. Thank you everyone to stay here in this section. My name is Dr. Wachiraphan P from Prince of Songkhla University. Welcome to my topic today about medical extrusion pattern in medial compartment osteoarthritis. Okay, the meniscal is a crescent-shaped fibrocartilage located between femoral condyle and tibial plateau in the medial and lateral tibial-femoral joint, and the function is of load transmission, load distribution, and shock absorption. Loss of this function, the load will transmit directly into the cartilage and lead to degenerative joint disease. So we will talk about the meniscal extrusion is a term used to describe the radial meniscal body displacement beyond the peripheral of tibial plateau margin. In normal, healthy, you use the MRI for detect and measure the extrusion. By draw a vertical line intersection the margin of the medial tibial plateau and measure from this line to the meniscal edge. Normal, healthy people have the physiological extrusion, but less than 3 millimeters. For the medial, meniscal can extrusion, but less than 2 millimeters. There are a lot of literature that propose the definition of the meniscal extrusion, just like the Costa and colleagues review the MRI and divided into minor extrusion less than 3 millimeters and major meniscal extrusion or more than 3 millimeters. Mustafa and colleagues try to convince that more than 2 millimeters should be cut point. Theodore and colleagues try to use the percentage of meniscus volume that extrusion from the tibial plateau. But nowadays, the definition is most commonly used is more than 3 millimeters. So meniscal extrusion is one early marker, and its value is predicting the development of the knee osteoarthritis. Many literature show us the patient who have the meniscal extrusion with normal knee X-ray will develop knee osteoarthritis within few years. What is the cause of meniscal extrusion? Meniscal extrusion have many pathologies, can divide it into meniscal pathology and non-meniscal pathology. Most common of meniscus pathology is meniscus root tear, and you can have the information for next topic. Also, another type of meniscal tear can have the meniscal extrusion too, especially in radial tear. And sometimes you can find your patient has meniscal extrusion without major tear of the meniscus. Most commonly is find in overload of the knee joint, especially in malalignment and obesity patient. Meniscus root is the insertion of the meniscus. Injury to this area will loss of meniscal hoof thread, and meniscal extrusion can be occur. And meniscal root tear is a major cause of meniscal extrusion. But sometimes you cannot find the meniscal root tear, but find only the meniscal extrusion. The structure that provides stability to the meniscus is meniscal tibial ligament. There is study to try to cut the meniscal tibial ligament and apply varus and valgus force. When applied, whereas the meniscus that cut the meniscal tibial ligament will display to medial. And study reviewed the MRI of the meniscal extrusion without a tear, found the abnormal signal at the meniscal tibial ligament more than 65% of cases. By conclusion, symptomatic medial meniscal extrusion have many pathologies. And intervention that should be applied to the patient depend on pathology you address. And most common cause is the posterior meniscal root tear. All of us know you should do repair or reconstruction for reconstruction the root. Is it good or bad? The meta-analysis show us the medial meniscal root repair resulting in improvement of the clinical subjective score, but meniscal extrusion was not reduced. Why this happened? We reconstruction repair the root already, but meniscal extrusion cannot still there. It depends on time. It relates to time of surgery. Delayed surgery more than 6 months was associated with the 7.8 times increased risk of meniscal extrusion and lead to 18 times increased risk of cartilage lesion. So another paper from Moon say early surgical repair of the medial meniscus root tear within 13 weeks from the onset of the symptom may be helpful to prevent the progression of the medial meniscal extrusion. Then meniscal root repair before 3 months may be helpful in prevent the progression of the meniscal extrusion. Another operation is meniscal extrusion reduction, or some literature says the centralization of the meniscus. Is the operation for purpose to return meniscus to the neutral position by retightening surrounding joint capsule, including the meniscotibial ligament, and stabilize meniscus itself. There are many techniques and instrumentation for this procedure. Like tibial tunnel, use an anchor suture for fixation or stabilization the meniscal tissue or meniscotibial ligament. But cannot conclusion which technique is the best for centralization of the meniscus. Example of the result of centralization technique by Wachiraphan and colleague cut the meniscus root and centralization procedure and measure the extrusion by ultrasound. And they found when cut the meniscal root, the meniscal extrusion can occur, and when do the centralization and apply some load, the meniscal still there. And another literature show the combined with the root repair. Is it essential or not? You can see when the anatomy tibial pull out root repair can restore hoop state of the meniscus, but when you repair and augment that with centralization, this technique is better restore extrusion of the meniscus. And high tibial osteotomy with meniscus centralization, they show no significant difference in knee score, in subjective score. But the film X-ray in high tibial osteotomy with the centralization is more widening of joint space compared to high tibial alone. So about the meniscus extrusion reduction or centralization is still question and indication to use. We still need to learn about the clinical result and indication for apply this technique. We are going to high tibial osteotomy and medical extrusion. There are MI pre and post of high tibial osteotomy 6 weeks. The show can reduce the medical extrusion very nicely from 3.9 millimeter to 0.9, but only 6 weeks, and the patient still non-weight bearing. For a longer literature follow-up 2 years of 18 years after high tibial osteotomy, the medial meniscal extrusion can reduce from 3.6 to 2.8 millimeter. But the symptom is, clinical symptom is variant. The patient with post-operative medial meniscal extrusion less than 3 mm have good clinical outcome, more than the one have the more than 3 mm. And systematic review of the last 625 cases show the significant improved clinical outcome of HTO and medical root repair, but not different from the, between the group. Well, high tibial osteotomy can reduce the meniscal extrusion and improve clinical outcome of the knee osteoarthritis, but clinical outcome will better in the patient who have post-operative meniscal extrusion less than 3 mm. But an osteoarthritis is still possible. So about the symptomatic meniscal extrusion, you must define what are causes of meniscal extrusion and try to correct as the pathology. The meniscal extrusion, what we learned today, the meniscal extrusion is can present in several knee pathology correlated with the rapid knee osteoarthritis progression. The film X-ray cannot detect this abnormality. Treatment options depend on the pathology. Most of treatment options improve the clinical outcome in short term, few years. Prevented osteoarthritis is still question. The future study in long-term outcome can help us make better decision making. Thank you for attention.